there was an occasion not that long ago where a clearly nervous patient was asked during pre-oxygenation by another member of the OR team, are you nervous? To which the answer is obviously yes. And it made the subject of the conversation the patient's nervousness rather than anything else. And it might have been a better strategy, perhaps, to say, to acknowledge the patient's nervousness, but to shift the focus a little and say, I know that you were very nervous about this, but look at how well you're doing. The way that you're taking this in your stride is really very, very impressive. How are you doing that?
Hello and welcome to a new episode of the California Society of Anesthesiologists Vital Times, the podcast. Today, I have the honor of speaking with Dr. Phil Jones about a favorite topic of mine, kindness and empathy. And we are going to discuss the interactions between healthcare professionals and their patients. Dr. Phil Jones is a cardiothoracic anesthesiologist. He studied at Magdalen College, Cambridge, and the University of London in the UK. He trained in internal medicine and anesthesiology and was appointed to a consultant position at St. Bartholomew's Hospital, London, where he worked for 15 years as an anesthesiologist and intensivist before moving to Toronto, Canada, where he now works at Toronto Western Hospital. I would like to thank Dr. Phil Jones for being here today and agreeing to speak on a topic that I'm passionate about. Dr. Jones, welcome. And if you could just tell us how you got interested in this topic to begin with.
Yeah, thanks, Dr. Lin, for having me. It's a real pleasure to join you. It went back actually to the time when I was training in internal medicine and I was doing a cardiology job. And I'm sorry to say I wasn't a very patient doctor, or especially kind even to patients. I got very frustrated at being paged and being rushed off my feet. And I had the great fortune to have a very senior resident who took me aside one day and told me that some of the patients were upset. And he explained that in a cardiology hospital, patients are really frightened. They're told there's something wrong with their heart. And he didn't know what else was happening in my life. But if I wasn't, as the first doctor to see the patient after their arrival, putting them at their ease, then something was wrong. And I was appalled, partly because it's a terrible thing to hear about yourself, but also because I knew it was true. And I resolved that I had to do something about that. It happened to coincide with me being about to start a training program in anesthesiology. And what's more, my mother, who had worked as a midwife for many years, had taken an interest in medical hypnosis. So these things all sort of coincided. And at the same time that my mother was telling me about the tremendous power of suggestion to influence how people feel and to empower them, whether it's weight loss or giving up smoking or whatever else, I found myself professionally in a place where, as a trainee anesthesiologist, I was with nervous patients going off to sleep. And of course, having been told that the way I interacted with patients really mattered, it was a fertile ground for me to start thinking much more critically about the way that I interacted with patients. And then I started getting positive feedback from people who worked with all sorts of different anesthesiologists. And obviously that was tremendously gratifying. And it fanned the flames of my interest in how we talk to people and how the words that we use and how we speak can make a difference.
That is a really great story. Thank you for sharing that. And thank you for being humble enough to admit that you had some downfalls as a trainee. I think that's really hard for us to admit. And I think it's a nice thing to be able to model for those listeners who are more junior. So I appreciate that a lot. Yeah, let's continue. So tell me more about the different elements that you resolve to incorporate into your practice.
I think it sensitized me a little bit to being on the lookout for things that might be negative suggestions to patients and that might influence how they feel. So, for example, it's very common to hear, certainly it was in the UK, and it's the same sort of thing here, that when we're putting the monitoring on patients, somebody will say something like, oh, we're attacking you from all sides, aren't we? And, it's intended to be an icebreaker, a joke, perhaps. It acknowledges the invasion of personal space that happens when we're attaching ECG electrodes and a blood pressure curve. But I think you have to bear in mind that it's probably not the best verb to choose, right? We're attacking you from all sides, aren't we? It's just, I think, a disastrous thing to say. You could say we're looking after you from, in stereo, or isn't it great to be surrounded by people that are here to keep you safe? You're the focus of our attention, and we want to make sure that everything is fine. But to choose attack is obviously not the most positive suggestion. And indeed, finishing it off with from all sides, aren't we, really suggests that there's absolutely no escape, just in case the patient wanted to consider the possibility that they might be safe after all. And the rejoinder, aren't we, is clearly a question, and it invites the patient to make a decision. Either they have to agree with the proposition that they are being attacked from all sides, or they have to somehow take a contrary position to the medical expert that's looking after them at a time when they are flat on their back, wearing next to no clothes, and they've just been presented with an assertion by a medical expert. Now, the power gradient there is enormous. It's very unlikely that people are going to disagree with what the medical expert or the nurse has told them. And I think that at a subconscious level, that's potentially quite damaging. We have an opportunity when we're doing putting the monitoring on or putting in an IV to create much more positive suggestions for patients, to empower them and to make them feel that they're doing well. Because people who are frightened are actually very receptive to suggestions. It's the same when people are in pain. It's especially true in the obstetric and pediatric population, neither of which I have much experience of, I have to say. But I think we should think critically about these sorts of things. And once you start thinking about it, then you realize that there are all sorts of things that we say that are unhelpful in terms of being negative suggestions. So before putting a cannula in, you might say, oh, this is a sharp scratch, or bee sting, completely forgetting that some people are mortally afraid of bees because bee stings can kill them, and nobody likes being stung by a bee, right? So it's an odd thing to suggest. If you tell the patient that they're about to have a noxious experience, then that's likely to be what they get. And I think it's important to remember that patients' experiences are very largely what you tell them that they're going to be. So just getting away from things like, this is the worst bit coming. A sentence that includes the words, this is the worst, is probably one to avoid. And there are lots of other things. I worked with an overseas colleague who said who explained to the patient, I'm going to put you to sleep now. I think oblivious to the associations that being put to sleep has with euthanizing maybe a much-loved pet. Another surgeon used to ask patients just before induction, any final questions? Apparently oblivious to the implication that the patient was now about to die, and the offer, although well meant, had more in common with asking a prisoner on death row, what they would like for their final meal or any final words before facing the firing squad. So I think in all of these things, it's just important to bear in mind the power of our words. And I think the COVID pandemic has led to a bit of a sea change in practice, in that I didn't used to go a bundle on pre-oxygenating people, but COVID changed all of that. And I think it's more commonly now the practice to pre-oxygenate people prior to inducing general anesthesia and inserting an airway device. And that's a golden opportunity for us to be able to just control the auditory environment in the room, try and make sure that there's not too much noise, that we're not tearing open sterile packs, that doors are not slamming as people walk in and out of the room. And we're just able to start suggesting to patients that they're safe and they're secure and everything's going fine. So some of it is the words that we use. Some of it, I think, is the way that we use our voice. When you think about actors, they are using their body and their voice in order to elicit an involuntary emotional response from us, right? Whether it's suspense or fear or laughter. And we've all got bodies and voices, and I'm not suggesting that we should try to make patients feel full of suspense, but I do think that we can use the volume of our voice sympathetically. We can bring it down in our vocal register so that we're not up here sounding all stressed, but we're down here sounding relaxed and authoritative. And you've also got opportunities to be able to change the rhythm of your voice, maybe to match a patient's breathing, to speak when they are exhaling, which discourages them from interrupting if you want to control the script or the spiel that you're using. And with a little practice, you can see that patients just start drifting off long before the drugs have gone into the IV. They close their eyes and they start to smile and they drift gently off to sleep.
I love that. Thank you so much for talking about these details that really make a difference. I happen to know that you were a very serious actor, so I'm not surprised that you're able to call forth these skills of modulating your voice. But, it makes a lot of sense when you talk about that. And you're right. I do think that patients are hypervigilant when they are about to be induced for anesthesia because it's scary. One of the main reasons I went to anesthesia was because there was one interaction I had as a fourth-year medical student doing a sub-internship in anesthesia where I was shocked to discover how scared this one patient was in the pre-op area, and that a good interaction did so much good for them, just in terms of that moment, that very moment's worth of quality of life. And we can do a lot to try to make that moment a little bit better. I'd like to ask you about how you manage your OR environment to maximize the effects of this. Because I hear what you're saying about you yourself controlling the way you interact with the patient to achieve these calming, reassuring results. And I think that one's pretty easy to do. How do you take the next step and convince the rest of the OR environment, the people counting instruments, the people coming in and out with large pieces of equipment, etc., to get on board with you, especially when teams are changing constantly, shifts are coming in and out. Tell me more about that.
I've been very pleased when other members of the OR team have sort of bought into the idea. And one of the reasons I think why I'm passionate about it is because there is a difference in culture and in logistics between the UK and North America. So in the UK, we usually have anesthetic rooms, which are completely separate from the OR. They're adjacent, but it's just you and your assistant with the patient. So you're remote from a lot of the sources of noise that are part and parcel of turning around the OR ready for the next case. And so to come to North America and find that patients are routinely brought straight into the OR, surrounded by stands of stainless steel instruments and knives, people that are fully gowned, the room is still being set up, and that they have to lie down on the table and not uncommonly get strapped in, which again is something that for fearful awake patients is not always comfortable. I regularly see people who say, look, I know you have to strap me to the table, but can you just wait until I'm asleep before you do it? Because it feels like restraint. And there's nothing relaxing about that. And once you've asked for people to be quiet, you often find that actually the other members of the team also sort of almost drift off into a little bit of a reverie. sometimes people will exclaim, I'm falling asleep myself here. Sometimes it's better, I think, if they can wait until the patient's asleep before they make that sort of declaration. But I think you try and encourage the behavior that you want. And where people are helping you by being quiet or by stepping out of the room prior to induction, if they need to carry on a conversation, then I think it's always nice to thank them for their consideration. And, I'll usually say that was just lovely. It was so beautifully quiet and calm and tranquil as the patient was going off to sleep. I really appreciate your efforts in that. I know it doesn't happen by magic, and it takes professionalism and discipline on everyone's part to create that environment, but I think it made a big difference. And I think a lot of people, get something out of that. It's important as the anesthesiologist not to expect people to be silent interminably. So once the patient's asleep, I'll say, thank you very much. The patient's asleep. Please feel free to go about your business. And people do. But the number of compliments that I've had since arriving in Canada from OR nurses especially, but also from surgeons, has really been very gratifying. And I think that the trainees in anesthesiology like it. I think they can see that being careful about what you say to patients matters. You don't have to say anything about the face mask through which they're being pre-oxygenated, but if you are going to say something about it, then saying that it stinks of plastic, is probably not very helpful. Telling people that the propofol is going to sting as it goes up their arm, really stingy feeling, is probably not very helpful. So you could say that it may feel very warm. Most people are not averse to feeling warm. You could say that the mask smells of summer meadows, if you like. I'm exaggerating a bit, but my point is there are countless opportunities for us to explicitly frame what we're doing to the patients in positive, reassuring terms. And it's been really nice actually seeing some of the OR nurses pick up the script themselves, and they've also been helping patients to just relax and take it easy as they're slowly drifting off to sleep and as the drugs are going in. So I think you just try and encourage the behavior that you want, and you ask people to try not to make a noise. I think when the drugs are starting to go in and you're pre-oxygenating, that's the time for an air of calm.
Sounds like what you do is you try to model this type of behavior, and with success, people jump on board. So that's good.
I think so. One of the things that fascinated me about the podcast that was broadcast a little time ago was you had a fascinating conversation about the empathy gap with some very distinguished guests. And one of the points that they made was that this can be learned. They made the point that some people just seem to be blessed with an empathic character, and it comes very naturally to them, and that's great. But as I've explained, I don't think that was true of me at all. And the point is that these are things that I am learning and actively trying to develop. The fact that I'm not personally predisposed to be able to do all this naturally hasn't stopped me from being able to learn it and to use it for patients' benefit. And I think there is another interesting aspect to this, which is that if you're faced with a difficult case and you're a bit nervous actually about conducting the anesthetic, if you are outwardly calm and focusing on your breathing and on moving slowly and deliberately, you actually feel calmer in yourself. You do this job of calming yourself down. It's rather like notions of mindfulness. And if you sound calm, it's much easier to remain calm. And if your assistants are also calm and you appear authoritative and in control, then they're very much more likely to be able to help you if you're giving clear instructions. If things get difficult, let's say the airway turns out to be tricky. When people are stressed, it's difficult for them to perform. And there's a lot of work, isn't there, around incivility and how that makes teams function less well and much less able to respond to critical incidents. And I think that part of that has to do with the way in which we talk to one another. So these things are all wrapped up. Being able to stay calm and in control, obviously important as an anesthesiologist, being able to utilize the other members of the team, being able to communicate clearly, being able to get a patient off to sleep who's not ragingly tachycardic and hypertensive with stress. All of these things, I think, converge to be of advantage to patients and staff alike.
Yes, I agree 100%. I feel like for somebody like you, who is at the height of your powers as a clinician, with experience, knowing that there are certain moments when you do indeed need to manage the entire OR very well, because, for example, it's a moment of crisis. You know how things are going to go, and you know how to manipulate it in a positive fashion. When you were starting out and you were training, and intermixed with the fear of being in that situation was also this worry that you might not come across as effective, that you might not come across as competent. Can you take us back to that period of your own practice and let us know how you managed to still exude this, type of empathetic behavior with your patients and with the rest of the team, and how you managed to calm yourself down to be able to execute that?
I think for me, it goes back to the sort of modeling behavior that you talked about a little bit earlier on. I was very fortunate, I feel, in my training to work with some really amazing clinicians and human beings. And I think in the end, we become composites of the people from whom we've learned. For sure, there are individuals who would work or talk or behave in ways that I didn't admire. And I might think, okay, well, I've registered that. That's not who I want to be. I'm going to try really hard not to incorporate those elements into my practice. But when you see people who are really good at something, including handling critical incidents, I think that's something that as anesthesiologists, we tend to pride ourselves on. It tends to be an important part of our identity. Then when you see that things are going wrong, you see your seniors take control. You see them remain calm. They demonstrate that it's possible to do, and you watch as they, I think, make the call between when they need to alert the surgeon to a problem and when they don't. And those are very powerful lessons. I'm sure that you and anyone listening will be able to think of occasions where they had these formative experiences of watching somebody really good handle a difficult situation well, and then you try to emulate that. And of course, the more you do it, then the easier it becomes with experience. But I think that modeling the sort of behaviors that we want to enable people to develop is crucial. And I think that how we talk to patients, particularly before they're going off to sleep and after their operations, is just part of this very broad spectrum of professional behavior. It's just that I don't think it gets as much attention, perhaps, as it might. If you're taking a patient to PACU, it's not that uncommon for the first question to be, how bad is your pain? Which assumes, right, that there is pain. It suggests that it's bad pain, and now it's just a question of degree. Or do you feel like throwing up? It's a suggestion to someone to feel nauseated and to vomit. So there are lots of other ways that you could pose the question. You could ask people whether they're comfortable. You don't have to use the word pain at all, and you don't have to suggest that they're going to throw up. So those are the sorts of areas where I would like to think that we can, as healthcare professionals across all disciplines, just try and think a little bit more critically about what we say, how we say it, and what effect that might be having on our patients.
Yes. One of my pet peeves is when people talk about being knocked out or having a colleague talk about knocking you out. Definitely
Yes.
one of my biggest no-nos.
I know it's completely associated, isn't it, with the idea of physical violence. And I understand that they're joking, but you do wonder whether patients necessarily have fully grasped that. And there are other ways of putting it. I'm not surprised. It grinds your gears a bit.
I'm also fascinated by everything that you've said so far. Is really challenging each one of us and all of our listeners to sort of pause, slow down, and think about the effect of our words and our body language have on our patients and each other for that matter.
Yeah.
And I've spoken during quite a few of these podcasts now about this concept that I've decided to term slow medicine. Slowing things down, not feeling like one is so pressured by our, current like productivity line to just get through things and to really be mindful, to use a current word, and to sort of take the luxury of time in terms of fashioning how we speak, what are we communicating, how to proceed. Do you sort of see what I'm trying to say?
I do. And I think that you make a good point. Certainly, as far as surgeons are concerned, most of us will have had the experience of working with surgeons who just make it look very easy. They're very unhurried, they're very unrushed, but they are efficient. So they don't waste time. But on the other hand, they're not exhibiting any signs of haste. And I think that in the grand scheme of things, the amount of time that we spend talking to a patient immediately before going off to sleep is not very great. And if you're going to combine it with, let's say, the period of pre-oxygenation, then actually it doesn't take any longer than doing it any other way. But the advantages for patients, you touched on this a bit earlier on, somebody who was very anxious. When you're able to allay that anxiety, particularly if you're doing it through non-pharmacological means, like talking to them and just enabling them to relax. It's almost a bit like hypnosis. Then that is going to affect that patient positively, not just for that hospital attendance, but of course, if they need to come back in the future, they'll approach it with that much more confidence. And one of the things that is really effective at enabling patients to relax is praise and encouragement for the patient. I think you have to assume that patients are doing the best they can. But even people who are really not coping at all well will usually exhibit some opportunity for you to give them some praise and encouragement. And you can just see some of the anxiety start to melt away as they are told that they're doing a great job. Now, it might be something as simple as just, offering you their arm to put the blood pressure cuff on, but saying thank you and, I'd said, you're doing a great job. Thank you so much for playing your part in the team and doing your bit. These sound like very trite interjections, but they're very, very powerful. And you can start to see the worry lines on people's foreheads disappear. And I'll give you an example. There was an occasion not that long ago where a clearly nervous patient was asked during pre-oxygenation by another member of the OR team, are you nervous? To which the answer is obviously yes. And it made the subject of the conversation the patient's nervousness rather than anything else. And it might have been a better strategy, perhaps, to say, to acknowledge the patient's nervousness, but to shift the focus a little and say, I know that you were very nervous about this, but look at how well you're doing. The way that you're taking this in your stride is really very, very impressive. How are you doing that? Now we're into a conversation about coping strategies. We're not talking about the nervousness. We're talking about overcoming the nervousness, about allaying it. completely different conversation, and one that suggests directly to the patient, even if they weren't coping with their nervousness very well, it suggests that they are. And that is quite empowering. So the more you can boost patients' confidence in themselves, the easier things become for them, and the easier it is for us to be able to gain and retain their cooperation. And I don't think it's too fanciful to imagine that people who are congratulated for overcoming their anxieties and for being able to, to come to the hospital and deal with something that they may have been very frightened about for weeks or even months, I think they should be congratulated. Why shouldn't that have a positive effect in other areas of their life where they might also be lacking in confidence?
I love it. I think this is such a positive way to have somebody go forward in their hospitalization process. And like you said, it's going to help them for their next procedure or their next experience. So thank you really for reminding all of us that this is, the way you've described it, this is part of what we do as professionals. And it's really nice to be able to discuss the nuts and bolts of it. Let me ask you about the way you implement this in your own day-to-day practice. There are probably some days that are not as good for you as others. How do you self-talk to make sure that you are true to this on a daily basis?
That's a good question. It's a tricky one to answer because I don't think any of us want to be sort of too prescriptive. The whole point about coming up with your own thing and ideas is really important. And I'm not suggesting that the way I do it is the only way or even the best way, but it's a way of doing it. And so I have to say that I tend to try to be as positive as I can all the time. So so for instance, just to kind of deconstruct perhaps the things that happen before induction of general anesthesia, when the patients are coming in, we'll talk explicitly about how, the other people in the room are all members of the team that are there to look after them. So we'll acknowledge, right, that there are other people in the room, but I would aim to describe it in explicitly protective and safe terms, that these people are here for you. If we're putting on a strap to make sure that the patient is secure on the operating table, we wouldn't say we're going to strap you down. We'd say something like, this is a safety belt. Right? Just like you'd have in an amusement park to make sure that you're absolutely safe, while we're looking after you. You don't have to talk about the surgery as wounds and incisions. You can talk about it as part of the treatment that's going to make you better. If there's one person whose work I would draw people's attention to, it's Alan Sinner, who is an Australian anesthesiologist and who has written quite widely on modes of communication with patients. So Sinner is Cyna. He's an anesthesiologist, I think, in Adelaide, in Australia. But he would talk very much and has written some great articles about positive suggestions. So when the monitors are going on, I might say the blood pressure cuff, we're going to check your blood pressure. It's a very tight squeeze the first time, but after that it calms down a little bit. You can think of it as a very, very affectionate cuddle on the arm from someone who's so pleased to see you. It sounds trite, right? But these are the sorts of things where you're just trying to adjust people's frames of mind so that things that are uncomfortable become innocuous, and things that might be painful just become uncomfortable. If you are in a positive, relaxed frame of mind, you often don't really notice things that are uncomfortable, and so the cannula may not really be perceptible as it goes in. Whereas if you've got people that are really ramped up and super anxious, then uncomfortable things become painful, and painful things become excruciating. The pain pathways are very, very susceptible to descending control. So what else with regard to the pre-oxygenation? I would just get them to breathe very slowly. And if you pace, if you speak during exhalation, then once you've done that for 3 or 4 breaths, you're setting up a link in the patient's mind between them breathing out and the anesthesiologist talking, which means that as the time goes by and you talk to them, if you start to prolong the time in which you speak, you'll actually find that patients' respiratory rate moves with your speech. So you can get patients to breathe more slowly and more deeply simply by using your voice and timing how you speak with their respiratory pattern. I tend to talk a lot about letting all the muscles in the face relax, letting all the muscles in the shoulders relax, so that the only muscles doing any work are the ones responsible for breathing slowly and deeply. I might say something like, you can make your breaths as slow as you like, as long as they're nice and deep. The point being that I'm giving the patient a choice, but I'm not saying don't breathe too quickly. There's no fast or negative instructions. I'm just indicating that they can breathe as slowly as they like, and that obviously gives me an opportunity to say the word slow. If you want to know whether someone is awake, I don't see much point in asking people to keep their eyes open as long as you can, which I hear a lot. You're trying to get them to go to sleep, right?
Yeah.
Not to fight it.
Yeah.
So if I want to know whether they are actually asleep before I give something that is painful on injection, maybe like rocuronium, or before I physically touch their face, I might ask them to wiggle their toes. And if they can't obey a command, then that's fine. Or I might ask them if they're warm enough, so that if they're not asleep and they recall the question, they don't recall an anesthesiologist who can't tell whether his own patient is asleep or not. They recall a polite inquiry about their comfort. And if they're wiggling their toes, or if you've got somebody under sedation, you just want to make sure that you're still in contact with them. You can ask them to wiggle their toes, and again, afterwards you can say, that's lovely, thank you very much, praise and encouragement. You can relax again completely. And that's a nice phrase. You can relax again completely has the word can in it, which in English has this nice double meaning, doesn't it? I mean, it sounds like I'm saying you have permission to relax again, but it also has the idea of to be able to. You have the ability to relax. And that's a powerful statement to make, especially if you follow it with the word again, which suggests to the patient that they were relaxed before, even if they weren't. And of course, how much do you want them to relax? Well, I'd like them to relax completely. Why not qualify it with something that suggests that the patient is going to be able to be completely relaxed? These are just forms of words, and we'll all have our own little scripts, but I think those are some of my favorites anyway. You can suggest to patients that they're in control of when they fall asleep. There's no reason why you can't say, and as you're relaxing there and breathing in and out, you can begin to start the process of deciding when you'd like to commence drifting off. It's just a means of filling the space and talking to them about it being a process in which they exert some control. For patients with a long arm brain circulation time, I think that's a nice thing for them to hear. Whether it makes a difference to patients or not, I don't absolutely know. But my inclination is that patients go off to sleep, I think, more happily. And most of us have had the experience of very distressed, tearful patients on induction, waking up with similar levels of distress, regardless of whether they've got significant pain post-operatively in the recovery room, right? So I think, there are lots of benefits. If you can avoid somebody bursting into tears, you don't have to deal with an airway that's full of respiratory secretions, right? So lots of good stuff.
Yes, that loss of control that is sensed by a patient, I think it's a very powerful thing. So to be able to give them back that control just by having this type of conversation is so powerful. I love it. Dr. Jones, I feel like I've been through this master class just now about language, how to use it, how to pace that language, how to direct the conversation. It's great. I appreciate it so much, and hopefully. This could be something that we can all incorporate into our daily practice. Like I said, I feel like I have come to this realization that slow medicine is such a important concept for me to sort of reclaim the practice of medicine for myself in this modern day world where everything is just, hurry, 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 and go, go, go. And your conversation is a call to action. We can do this, and it takes some effort. It takes a lot of management, but that's part of our professionalism to bring that to the or environment. So I'm going to utilize this moment to wrap this up. Do you have any conclusions for our listeners about this topic?
I think I would just say that it's made a big difference to me. As I said at the beginning, I needed to do something because I wasn't interacting helpfully or sympathetically with patients. And to some extent, I think my enthusiasm for this reflects the zeal of the converted, perhaps. But I'm not in any doubt about it being a positive thing in terms of making patients feel that they matter and that they're genuinely important to me and that we're going to care for them. We're going to look after them. I think that sometimes gets lost in the hurly-burly of the frenetic pace of life in hospitals. And I think the series that you're doing with these podcasts is very important, as you say, in reclaiming something of a lost art. I think our forebears were much better at this than we are. But it's teachable, it's learnable, it's tremendously powerful, and I would never go back to the sorts of things that I used to say during induction, having found much more positive and sympathetic and encouraging ways of doing it.
It's beautiful. Let's learn it and let's put it into practice. Well, great. Dr. Jones, thank you so much for taking the time. I have learned so much.
Thanks so much for having me.
Well, yes, of course. This will conclude today's episode of the California Society of Anesthesiologists Vital Times, the podcast. Please give us a follow, and we'll see you next time. Take care.